sugar in it to make it more sweeter.
They put what in the orange juice?
Like packages of sugar, like regular sugar.
Yeah, the good thing about orange juice is it doesn't have a lot of sugar. Granted, it's 20-something grams of sugar. But like apple juice has like double the amount of sugar that orange juice has.
Yeah,
and they don't need to add sugar to it. It's already enough. So.
Or I always see them put packets of sugar in their mouth too, like telling them to take.
Yeah, that's a quick fix. Again, it dissolves underneath, and it's getting into the bloodstream a lot quicker. So yeah, that I've done that too. When I didn't have something else sweet, and I just found some sugar packets, I'll just take those sugar packets and put them under my tongue and let them dissolve and get into my bloodstream. Really, there's no reason to put sugar into the orange juice. I mean, that already has a lot more sugar than the sugar does. You know, if you're wanting more, then, you know, get an order for D50 or something, or give them more apple juice.
Yeah, because I see some that my residents would be like less than 40.
Now remember, are they altered? Because if you give them anything by mouth, they're not able to protect their airway. They can choke on that.
No, they're still like fine, and like they're just like kind of disoriented a little bit.
Okay. Well, as long and a good rule of thumb is for the glucose tube is if they can hold it in their hand, they can protect their airway. And that's 15 grams of sugar, so it's not as much as orange juice, but at least that's giving a little bit more sugar. Now, you know, it is. I'm talking more from an EMS perspective. I can't really speak much for a nursing perspective, and I don't want to make it a us versus them type of battle and mentality. But you know, are they notifying the doctor that their sugar is dropping too much? Because a lot of diabetics, like even with my dad when he was in the hospital, and then in the past too, he had a sliding scale. Depending on what his sugar was going to determine how much insulin he got.
Mm-hmm.
And that was the same thing with me too when I was in the hospital. They give them a sliding scale. So if it's between 150 and 200, you'll give them 5 units of short-acting insulin. If it's 200 to 250, then you know it's this much. So that's what a sliding scale is. So are they doing it? Are they not doing it? You know, are they like, hey, wait a second, this patient keeps becoming hypoglycemic when we're giving this amount of medicine. Maybe we need to let the doctor know to adjust their medications.
Okay.
But, yeah, I don't see the need, but again, I can't speak much to nursing practices, but in EMS, no, they the glucose tube and they'll just give them another one. But I have another option. I could start an IV and give them D50 directly into the bloodstream. And so that's really sweet, thick, and that's going to raise their blood sugar pretty good. What else? How long have they been this way? And why is that important to determine?
What was that, Luke?
Why is it important to determine why or how long they've been acting this way?
I guess to see if they've had any history of anything more critical. No?
Doesn't it have to do with like how long like you're starving your brain? No, you're not enough sugar or something.
No, don't overthink it. It's a real simple answer. And that answer is to help us determine whether it's hyperglycemic or hypoglycemic.
Oh, okay.
Because with hyperglycemic, what's the onset time?
It's a slower rate.
It's slower. It's gradual.
Gradual.
Whereas with hypoglycemic, what's the time of onset?
Rapid onset.
Rapid onset. That's why it's important to determine that. Also, have they had a seizure? Have they been sick recently? Because again, what's going to happen to the sugar if they've been sick recently?
It's gonna increase.
It's going to be increased. It's going to be elevated. Yeah. Okay. All right. Other things to look at. Uncharacteristic, bizarre behavior. So they might be acting goofy. Sometimes too, and this has happened to me, and people have mentioned it to me. I tend to be nastier when my sugar is really high. Although thankfully, it's been a long time since it's been really high. But yeah, I was a kind of a different person. I wouldn't take shit from anybody. I'd be knocking people's heads off. I was nastier when my sugar was really high, and people are like, "Lou, go get your sugar checked. Go do this. Go do that." Something else to maybe look at, and it kind of reminds me of that motorcycle accident that I told you guys about. Remember the dude that had an injury to his liver?
Yeah.
You remember that story?
Mm-hmm.
Yeah.
So
Okay, so he had a bruise over his abdomen, and so I asked him if he did, and I think I mentioned it to you guys too. Is sometimes when you're injecting insulin, sometimes you get bruising under there. You penetrate a blood vessel, and it bleeds, and then a bruise develops. So when you're assessing them, if they're, for example, and you close them, look at the abdomen. Is there any type of bruising on the abdomen? And multiple bruises, and it's in other words, it's not like across the abdomen like a seatbelt would cause. There's damn, somebody's making breakfast. Sound like.
I think it's Paul just making noise.
Yeah, most of the time it is Paul making it.
God, Paul, keep your mic.
Ooh-wee. Sequoia.
Yeah, she woke up on the bed this morning.
She did. I wonder why.
It's too hot and she couldn't get comfortable.
Or
More like I didn't sleep, so because I had 2 cups of coffee, breakfast, I'm good right now until I start crashing about 12.
Well, that's almost. So going back to
so are you saying that class is boring? Because it's really not.
No, it means that it actually wakes her up, and once class.
Come on, Lou. Come on, Lou. You could have my back a little bit.
Nope. Not at all.
I'm not going to be agreeing with that. Then you're saying I'm boring and I'm putting her to sleep. It's actually the other way around. You get.
It was on her.
If you've ever noticed,
Getting in
sometimes
trouble.
I start talking nonsense, it's because I'm falling asleep.
Because we're boring, huh? Because nobody talks.
I'll plead the fifth.
It's okay, dude.
So what do we do with ultra mental status patients? Obviously, we're going to check a BGL. Now, I don't think it was you guys. I think it was the night class. Somebody's like, "Oh, they're drunk." No, you know what? We can't assume anything. I've told you guys that before. If you see somebody that's behaving inappropriately, if they're out of it, and it appears that they might be alcoholics or drug users, again, don't make any assumptions. Yeah, the reality is that most likely that might be the cause, but remember that intoxication mimics diabetic emergencies. So always get a BGL. Find out if it's the sugar that's causing this issue, and if it's not, then there's something else. At least you ruled out diabetes. Because remember, if we become hypoglycemic and we get pretty close to 0, we are going to die. Because how much sugar is the brain getting at that level? At 20, at 15, at 10, at 5. How much sugar is the brain getting?
Not
Not
enough.
really.
Yeah, hardly anything. And we know that the brain is that needy that it's going to get that sugar as soon as it can. Okay? So, as far as reassessing for your diabetic patients, your altered patients, you can reassess them every 15 minutes. Okay. Unless they continue to be unresponsive or altered, then reassess them every 5. Once they're up and about, the sugar should be fine. They shouldn't need much reassessing. But if you start seeing them acting abnormal again, and remember that the hypoglycemia comes in suddenly. If you see them all of a sudden start to sweat, they become pale. If you notice that they're starting to become a little bit out of it, then obviously their sugar dropped again. And so more needs to be done for them. Okay. Understand that at the ALS level, and I try to teach this to my advanced students, and some companies like Life doesn't necessarily agree with this that I say, but it really is true. You know, I've been doing this a long time. A lot of times when a hypoglycemic patient is altered and we give them sugar, and this could be a BLS call as well, we give them some glucose and they come around. And remember when we talked about legal issues and consent?
Mm-hmm.
Yeah.
Yes.
All right. So we give them sugar and they're with it now, and we determine that they're ANO times 4. They could answer a person, place, time, and event. Can we force them to go to the hospital?
No.
Nope.
No,
No,
can't.
we can't.
Can't advise them.
Exactly. We can't force them to go to the hospital. They're a competent adult. So you can't take them. And that's usually what happens. Okay. As long as they're with it, maybe give them a little bit more sugar just to make sure, and tell them to eat. And maybe don't even leave until you see them eating or making themselves some food. Because again, the sugar may drop again and where you're not there. But if they don't want to go, once they're ANO times 4, you can't force them to go. Okay. Any questions?
No.
Okay. So there's not a lot of diabetes. The main thing is that it's the pancreas not working appropriately, either not producing any insulin at all, or not producing enough insulin to be able to get the glucose from the bloodstream into the cell. In fact, what's happening is the glucose in the blood is drawing fluid out from the cells and from the interstitial area, the area in between the cells. Eventually, what starts to happen with prolonged high blood sugars is that not only does a person lose weight because of the breaking down of fats, which is a good thing, but then it's also a bad thing because you have all that sugar in your bloodstream. But eventually, the diabetes starts attacking muscles. And so weakness can be common after a while. A lot of weight loss is common. That's one reason I lost a lot of weight too, was my diabetes. I'm going on 15 years as a diabetic. What else? Just do your assessment, establish the time of onset, look at their skin signs. Those are going to be the giveaways as to whether they're hyperglycemic or hypoglycemic. Okay. If in doubt, if you're able to administer oral glucose, then just go ahead and do it. If it's low, it's going to help. If it's high, it's not going to really hurt. It's going to raise your sugar up a little bit more, but not significantly enough to cause major problems. It's already high. Okay. Reassess your patient. Once they're with it, if they refuse transport, then there's nothing you can do about it. Okay. So diabetic patients, there are a lot of Americans or a lot of people in this country that are diabetic. You will see a lot of them going to dialysis, and they have some sort of history of diabetes as well. So you'll see a lot of that. And for the most part, it's not much. Taking them to the hospital, and this is why I kind of say don't push it, is because you get them to the hospital, they'll check the sugar. They'll either give them more sugar or they'll give them some insulin. Then they'll give them some food, and then they'll discharge them. So there's not a lot of stuff to do. Okay. ALS can't start an IV, can't give them fluid up to about 1 liter. And what that's doing, it's diluting the blood. So they have to be very careful about how much fluid to give them. But that's ALS level, just so you guys are aware. The blood can be diluted to decrease the blood sugar, but too much dilution can actually affect the blood chemistry. There are consequences to high blood sugar over a period of time. Higher incidence of heart disease, heart attacks, strokes, renal failure, high blood pressure, because the excess sugar is damaging the body. Okay? And then a lot of peaks and valleys, high sugar, low sugar, high sugar, low sugar, can also be bad for the body, the kidneys as well. So diabetics need to try and maintain their sugar at a constant level, and go from there. Okay. So make sure you finish reading. If you haven't finished reading, make sure you're doing your homework, because your homework is due on Thursday. That's your next exam. Tomorrow we're doing what are we doing tomorrow?
I think it's anaphylactic reactions.
Yeah, allergic reaction. So that's not too bad either. Part of it we've already talked about. Well, we did talk about it. Remember in shock?
Yeah.
It's a type of distributed shock. So we'll just kind of talk about allergens. We'll talk about antibodies, and histamine, and what the consequences are of an allergic reaction or anaphylactic reaction. And you've learned what to give the patient in having an anaphylactic reaction. So there's really not much to cover tomorrow. So we should be done early. Like I said, you should have enough time to finish your homework. Okay, it is due on Thursday. Questions?
No, sir.
Lou, does which?
Uh-huh.
Oh no, nothing.
Okay.
That was 20. We're
So
going to
grades will
21.
be posted on Monday after the test.
Well, what?
Grades will be posted after the exam,
Yeah.
like on Monday. All right.
Yeah. Anything else?
No, sir.
Can you
I think that's
post
it.
chapter 21
No.
on the file?
Yeah, I'll do it when I get to the office.
Okay.
This computer's not very good for that stuff.
All right.
I don't like to
Sounds
use my
good.
personal laptop.
All right.
And will we have a quiz tomorrow too?
Yes, ma'am.
Okay. All right. I don't got anything else.
All right. Did you guys come up with an answer for the CPR class?
Mostly
I think
everything.
we're going to do it
Next
next
Friday.
Friday.
Next Friday?
Yeah, so if you can see what do you think the earliest time that Paul will start? Because it's still going to be in groups, correct? You said no more than 6?
Yeah. Because that CPR thing, ratios 1 to 6.
You think he'll be here about 8?
Oh yeah.
So we can do 8 and 3-hour class, though, right?
30.
It's a 3-hour class, right?
Give or take.
So 8 to 10, 8 to 10:30.
I mean, he could do at 7:30. He's usually on those days, I get there at 7. He's already there.
Oh, that's even better.
Okay.
I'll see if he wants to do 7 o'clock.
Yeah, because I don't want to.
I can't do. Well, I'm going to get there late then because I get off at 7.
All right, so 7:30, 7:30 to what kind of the same 7.
Yeah.
7:30 to 10:30.
9:30, 10 or 10:30. Yeah.
Yeah, it's better. Yeah. No, well, you're not rushing, and we got time to disinfect. Or you guys got time to disinfect. So 7:30 to 10:30, 11 to 2, 2:30 to 5:30. That's the 18 shit. So we'll probably have to do it in 2 days.
No, that's fine.
Well, that's good because I think there was somebody that says he works the weekends, Friday through Sunday. Oh no, but you said it can only be on the weekends, huh? That's right.
No, he said Friday too. Friday, Saturday, Sunday.
Yeah, but I think somebody said that they work the weekend,
Well,
Friday through
get a
Saturday.
list. I'll ask them, but and what they could always do too is they can come in and sit in on one of our healthcare provider classes. Although those are usually Friday and Saturdays.
What was
I'll have
that?
that person get a hold of me and we'll figure something out.
Okay. No, that's fine.
Did somebody just say something?
Yeah, me.
Well, what did you say?
I
No,
said,
not Lou. Not Lou. I thought I heard somebody say something about the Saturday, Sunday, or Friday, Saturday. My fault. Excuse me. Sorry, guys.
no worries. All right, so I'll tell them next
Okay.
Friday.
Yeah, it's gonna be Gerardo.
Yeah, it's me. Gerardo,
Yeah.
I can't do it on the weekend. Friday, Saturday, Sunday.
Yeah, it's Herrera. So can you do a Friday?
I wouldn't be able to. I work Friday, Saturday, and Sunday. It'll be Monday to Thursday.
Okay, then you would have to go with Lou then, because we're gonna do it Friday, Saturday. So that way you
Okay.
can get in with the group with one of them.
Yeah, I'll go ahead and talk to Lou.
All right, that's fine.
Look, I was saying Friday, Thursday. So on Friday, we can't get everybody through. It's gonna have to be 2 days.
That's fine.
So,
Because what is it? 7:30 to 10:30. 11 to 2. 2:30 to 5:30. So that's 3 groups.
yeah,
So that's 18.
you know it's gonna have to be more than that.
What do you mean?
Because don't we have 26?
Yeah, it'll probably have to be like 4 groups.
Because I have class Friday night. Okay, I'll see, but HA says 1 to 6.
Okay.
Although, actually, you know what? I have a solution. Okay, we might be able to get more. I'll let you guys know tomorrow.
Okay.
All right.
Okay. I got to make a phone
Have a
call.
good day, everybody.
I'll let you guys know tomorrow as to what I worked out, but we'll plan on next Friday.
Okay.
Okay.
All
All
right.
All right. Y'all have a good day.
Bye.
All right. I'll talk to you later.
Bye, guys.
All right. Bye.